So it's 2 o'clock, so we start this third IAADM network meeting, 26th of September, and the meeting will start now till about half past 3. The only thing that Helene is not here, so I cannot, or somebody is helping me to let the people in. That's great, thank you. Because every time there are new people, so I give a short introduction about IAADM, the International Association of Assisted Dying and Mental Disorders, and the IAADM was founded in 2024, almost 1 year ago now, and we hope to foster international multidisciplinary collaboration in education, research, and clinical care regarding medical assistance in dying for individuals with mental disorders. And we hope to support ethical, clinical, and legal and societal debate. We have an executive board with Richard Oude-Voshaar, Kenneth Chambret from Flanders, and we are still installing the advisory board. We have members for the advisory board, and then we are planning to start to have the first meeting in the end of October or the first part of November. And we hope to expand the network with the advisory board to provide the input, to introduce new ideas, and we hope that they will play, and I expect that they will have an active role in all our activities. So we have the network meetings 4 times a year. One part consists is a scientific presentation of one of the members of the network, but we also can discuss a complex clinical case, for example, and one part is a presentation from one of the countries about an update of the legislation on MAID. And we're also planning to have the training and education programs. We can discuss the programs of all the countries, and we are planning to have an international symposium in 2026, but the schedule is quite busy in 2026 because there's the IPA meeting in Leiden. It will be the beginning of July, and there is the ICEL 5 meeting about in Brisbane, and it will be in April. So we are still busy. When will we have this symposium of the IAADM? But you will hear about that soon. So today we have 2 presentations. One presentation is from Richard Oude-Voshaar. He's now in Japan, so he recorded his presentation, and I will share the presentation. It's about that which is later live. And then afterwards we have the presentation from Canada, from Cindy Grieve and Chris Kitamura, about the developments in legislation, an update on MAID in Canada. So I think it's a very interesting program. And I will start the first presentation of Richard, and I have to stop sharing this part, and I have to share another thing, but I hope. I hope I will succeed. Let me see. I will share this one. Do you see it? Do you see the presentation now, or I'm not sure about it? But maybe I have to do it in a presenter mode. This presentation will be about the death wishes in later life, and we have quite a focus on geriatric psychiatry this afternoon. Death wishes in later life and reflections on death often become more salient. Shifts in social roles, for example, the burden of age-related diseases and the prevalence of common mental disorders may contribute to complex attitudes towards life and towards death of the older people. And in this lecture, he will present and critically examine the empirical evidence of death wishes in older adults. So let me see, because I also have to do the lobby, and John Bernheim is coming in. I hope he will succeed now, because he's still waiting and I cannot let him in. So, well, I will try later on. I will start the presentation of Richard. Afterwards, we can discuss about it and we can ask questions. And I don't know if I can answer all the questions, but I will try. And we have geriatric psychiatrists here, a few. So I will try to. Oh, that's the end. Sorry.
Welcome everybody, thanks for the invitation to give a lecture on death wishes in older adults. My name is Richard Oude-Vosser. I'm professor of geriatric psychiatry at the University of Groningen, and I will present you some research I did on suicide and especially the relationship or the difference with death wishes in later life. First, I would like to present some suicide rates from the Netherlands. On this slide, you see the suicide rate in 1980, so about 40, 50 years ago, and it is presented per age group. And what you can see is that the older an age group, the higher the suicide rate is. And that's the same as internationally seen in all different countries. If you still look at the year 2000, so 20 years later, you see that suicide rates up to 40 years remain a little bit stable, but thereafter you see a little bit of decrease. And when you look in 2023, and especially put 2000 in the middle, because in the year 2002, the Euthanasia Act has been legalized in the Netherlands. So maybe we can see whether that affects suicide rate. But what you see is in 2023, suicide rates are nearly similar to those before euthanasia was legalized. You see a small difference, however, in the oldest group, but that's difficult to interpret as numbers are small. If you look at age differences, it is known that men are about 2 times more often commit suicide than women, and that trend you see worldwide is also seen in the Netherlands. And if you look at different age groups, here you see for men the cohort effect, and what you see is that the cohorts of in 2080, 2000, and 2023 hardly differ, with the only exception that in the oldest old, suicide rates were very high in the oldest old men, and they decrease in 2023. Look at Dutch females, you see that the highest suicide rates are at the end of midlife, with a little bit of decrease in the oldest old, and you don't see a clear trend after the year of 2000. So whether the legalizing euthanasia affects suicide is very difficult to say. Maybe there you can see a trend in the oldest old males. In the past, I did some research on suicide in late life, and I've used, in collaboration with the National Confidential Inquiry into Suicide and Homicide by People with Mental Illness in the UK. And that's a very large project. It was launched by Professor Appleby, and what they did was they registered all deaths by suicide in the United Kingdom, and checked whether they had been in contact with mental health services in the year before the suicide. And in that case, a booklet was sent to the mental health care team, and they had to fill out all factual information about that patient and some subjective things that they had to complete with the team. And it is very good supported by the government, so response rates were very high. And so we had that psychiatric data on more than 24 of almost 25,000 patients who had committed suicide. And I did some studies with a focus on late life. And on this slide, you see a summary of findings we did in older age. And I think there are four important conclusions. First is that in 1 out of 6 suicide cases in later life suffer from an anxiety disorder. And this is rather high because we are usually think that depression and personality problems are the highest risk factors for suicide and of course substance use disorder. But it is important to realize that anxiety is often involved. When you directly compare younger cases with older cases, it is interestingly that older cases are characterized by less severe psychopathology, with a more prominent role of physical and functional decline, and by more social isolation. So you see that the contribution of psychopathology becomes less and more aging-related changes play a role. Also interesting is how clinicians rate the suicide risk. And if you compare their ratings for individual patients, clinicians rated the a priori suicide risks in the consultations before the actual suicide lower in older patients who committed suicide compared to younger patients who committed suicide. And when you look in the older cases specifically, they rated the suicide risk lower in late onset cases compared to older people who had an early onset psychiatric history. And so clinicians often think that in late life, suicide is not a big risk, or at least less than in younger people. And most interestingly, or maybe scaring, is that older adults were less rigorously treated than younger cases. So it seems that if you think that the risk of suicide is high, you do everything to prevent them from suicide and treat as good as possible. But you see that the older a person is, the less rigorously has been treated. So that points to some kind of ageism. What I also did in Manchester, United Kingdom, is to collaborate on a project of self-harm in later life. And self-harm is very important if people present at the emergency department because it is a significant risk factor for future suicide. And the idea is that that self-harm leads to cognitive sensitization. People habituate for the negative effects of self-harm, and they acquire some competences for suicide. So every time they harm themselves, they come a little bit closer to completed suicide. And what we did, we looked at the people who first presented with self-harm at the emergency department and looked at predictors for repetition of self-harm. And what we found when you compare younger adults with older adults, you see that the repetition of self-harm is higher among younger or adults. So a higher age prevents or protects from a repetition. And the other risk factors for repetition are non-white ethnicity, psychiatric treatment, of course, misuse of alcohol, hopelessness, and somatic health problems. But what was very interesting, that the risk of self-harm, of the repetition, is higher in younger adults. If you look at death by suicide as an outcome, it was significantly higher in the older people. So older people less often have a repetition of self-harm, but more often result in a completed suicide. So it means that self-harm in late life is especially important. And if you look from a perspective of as a psychiatrist, you also have to evaluate patients at the emergency department and you make a decision what kinds of care is needed for this person. And this is a very interesting study. I was not involved myself. It's a very big cohort study with almost 40,000 patients who presented with self-harm at the emergency department, and they have been followed up for 12 months, and about 2% died and 0.7% completed suicide. And if you look at the hazard rates by the different treatment approaches, you see that all have increased risk to die in the next 12 months. And if you look at suicide, then you see that patients who were medically admitted to a medical ward, who have been referred to mental health care follow-up, and who were admitted to a psychiatric ward, all had an increased risk of completed suicide. And that's also what we know, that we often say, well, if you put patients on a psychiatric ward, it might increase the risk of suicide. So we have to focus on autonomy for patients. However, it was very interesting to see that if you adjust for age, sex, type of self-harm, and all the psychiatric history variables, you see that it does not, the specific intervention does not increase the risk for mortality or suicide anymore. So the fact that people more often commit suicide when they are hospitalized probably is more related to the psychiatric history than to the fact that you hospitalize them. I think that's not the most interesting, but when you look at age, it is very interesting because the authors found an interaction between age and outcome with respect to mortality and suicide. And what they found was that in the younger people, younger than 25 years, admission to a psychiatric ward increased the risk of mortality and of complete suicide. But in older people, admission to a psychiatric ward prevented people from suicide. So the general tendency to not admit patients to a psychiatric ward after a suicide attempt or self-harm is completely different in younger than older people. And in older people, we should more often be protected. So that I think I would like to say about suicide in older age. And now I would like to make a switch to death wishes in more general. And this is a study we recently published from a big cohort of more than 1,700 older patients who have been referred to geriatric mental care. And it was outpatient care, and we just asked them systematically whether they had a wish to die. And 17% report to have such a wish. 12% was ambivalent about whether they really want to die or not, and 4.7% was quite specific and would like to die. And then we looked at what would be independent predictors of death wishes in a population of older people who have been referred to specialized mental health care. And of course, suicide risk is the most important prevalence, and also depressive symptom severity and the presence of a depressive disorder. But even if you adjust for these very important psychiatric parameters, the feeling that one's life is completed was independently contributed to death wishes. So death wishes in a psychiatric population are not completely determined by psychiatric or disorders or psychopathology. And this is also reflected in another study we did, the NESTO, the Netherlands study of depression in older people. We followed 285 patients who had a depressive disorder according to DSM criteria, and 137 remitted fully at 2 years, and the others did not remit. And what you see in the subgroups of the patients who were remitted, 23% of them still reported thoughts of death or thoughts of suicide. So their depression was completely treated and in remission, but thoughts of death remained. So that means thoughts of death are very more multifactorial in later life. Now, it's always important to how you can really predict suicide in general and also in later life. In this slide, I put some meta-analysis on prediction studies, and what you see is that the accuracy to predict a repeated suicide attempt is very difficult. And on average, the positive predictive value is 22%, so it's very difficult to predict a new event, and the negative predictive value is 89%. So we are pretty good to be sure that a person does not commit a second a suicide attempt, but it's very difficult to predict that they will do. And also important is that clinical judgment. We all do it at the emergency department, and hardly any failure. If you have a computer algorithm based on all knowledge available in the electronic medical dossier, and you compare it with clinical judgment, you see that the computer algorithm can better predict whether people would attempt a suicide again or not. And also, if you have systematic risk assessment tools, it is only moderate. And the area under the curve in meta-analysis is only 0.67, which only a little bit more than 50-50 chance. So prediction of suicide attempts and completed suicide is extremely difficult in clinical practice. And I think that should not be the main aim in clinical practice. In clinical practice, it is much more important and how you translate risk factors like male gender, psychiatric history, a history of self-harm and attempted suicide, suicidal ideation, somatic disease, handicaps, and pain. There are risk factors which you should look if a person has this kind of risk factors. How can you translate it for that specific person? In what does it mean for the loss of meaning in life, for the disconnectedness of relatives and his or her social circle? And what can we do about an accumulation of a painful life? People have accumulate all kinds of stresses and they have to cope with it. And people fear the loss of control and autonomy. And I think if you look at qualitative studies and also you listen carefully to your own patients, these are the issues that are important. And I think in clinical practice, we should look to these kinds of concepts and try how we can help our patients to improve this, rather than simply making a risk estimation. Now, if population aging, this is a talk about death wishes in later life, but aging challenges to think about quality of life, end-of-life decisions, completed life. It becomes more and more important. And it also stimulates a little bit research in this area. And if you look at the epidemiology of death wishes, I reported it in my studies just from a psychiatric perspective, and show that it is high in psychiatric populations and not fully dependent on a psychiatric disorder. But if you look at the epidemiology, the assessment of death wishes varies between studies. It is very difficult to compare because everyone uses a different measurement, and measures differ in the intentionality of death wishes. You can explicit asking for persistent death wishes, serious, repeated death wishes, or just simply quick thoughts. The framing of the question, it makes a difference when you ask to a wish to die or you don't have a wish to live anymore. The time frame, had you ever a death wish of death in the past week or past week? How stable is it over time? And it also makes sense whether you ask it self-reported paper or just in a clinical interview. However, despite all these limitations, you can put it a little bit together, and then you can figures like this that put it myself together. And what you see is that the first study, that it's a Dutch, very large study in 50,000 people, and it are people who had say they had no serious medical illness and no psychiatric illness. And then still 1% of the people aged 55 years and older reported the death wish. If you look at the general population, you see death wishes in about 3 to 4%. So that's quite a lot. One study was very exceptional high of fourfold, but that study was conducted in people aged 75 years, and it also asked it at 2 different time points, and about a third of the people who had death wish reported to have it on both time points. So that may explain why it is a little bit higher. And if you look at specific patient groups, like patients with a specific medical disorder, then death wishes go up, and that makes sense because having somatic problems and disability increases death wishes. And you see, for example, also the highest prevalence in the study of Durst et al. It was in a population of people who had a geriatric rehabilitation clinic. So they are a little bit older and seriously disabled. So it makes sense that they reported the highest prevalence rate. Now, if you look at the phenomenon, you can say simply from an epidemiological perspective, do you have a death wish or not? But if you ask people qualitatively, they have very sad narratives, like feeling a wreck, feeling a prisoner in life, or feeling a burden for others. And it all qualitative studies refer to the loss of dignity, loss of autonomy, social exclusion, perceived usefulness, and the narrative disintegration. Their life story ends, their life seems like a closed book. And all these phenomena points a little bit to the interpersonal theory of suicide. It simply states you need to perceive yourself as a burden for others, and you should feel that you have a trusted belongingness. And if both are present, then you need an ability or an acquired ability to commit suicide. And only that last part is a little bit makes that one can commit suicide. But you see that the origination of death wishes fully fits with the interpersonal theory of suicide. You can make also models of how you can explain death wishes in later life, and especially when they are a little bit fluctuating over time. And I like this model. It's based on epidemiological studies combined with qualitative studies. And it simply says, if you look at the upper side of the slide, you have a desired situation for everybody and a real situation. And life events, problem with aging and illness depends a little bit where on the continuum you are. And your personality, coping strategies, and social support means how good you can deal with it. And when you age and you get a feeling out of control, you become out of control that you can't realize the desired situation anymore, you can progressively give up. And then it becomes in the next step that you try to reclaim control by developing thoughts about death as a positive thing or a release of problems. So death can be a solution. And when you see it, if you look at this balance of feelings towards living or dying, then the wish to die can be strengthened when people consider the negative sides of living and consider the positive sides of dying. And the wish to live is a balance of considering the negative sides of dying, like not wanting to commit suicide for their relatives or scared of dying, and considering the positive sides of living, like family, hobbies, nature. And just those wishes to die and wishes to live is just a delicate balance, and it may change and fluctuate a little bit over time. And I think this is a model you can look where your patient is and what can be a target for treatment. If you look more from a research perspective, then you have different determinants of death wishes, and they can be psychological, social, physical, and existential, and I think all have meaning. Like I also showed in completed suicide in later life, psychopathology is one thing, but other components are much clearly present in late life. If you look at psychological determinants, psychopathology, bereavement, depression is important, social, financial stress, social network size, loneliness, disconnection. Physical, of course, functional decline and pain are very important. Chronic illness is also, but I think a little bit less. And loss of autonomy is most important. And existential determinants are lack of meaning and feeling of burden for others. And if you look a little bit in more detail at these determinants, you look at psychological determinants, I think depression is generally considered an important determinant, and it has indeed been consistently associated with death wishes in epidemiological studies, but the explanatory power is quite limited. So you can ask yourself, is it really depression that is the most important determinant, or is demoralization not a better perspective, just losing hope? And if you ask in qualitative research, you see now, especially the identity disruption and the narrative collapse. So a death wish is often a symbol of a profound existential disorientation, and loss of identity is often associated with functional decline, autonomy loss, or social disconnectedness to relatives. And this argues for psychological models of death wishes beyond psychiatric disorder. And if you look at social determinants, loneliness, social isolation, and exclusion has often been studied in epidemiology, and they have more impact on death wishes than depressive symptoms. And if you look, for example, from the progress from functional decline to a death wish, then loneliness and social isolation is often a mediator. So people decline functionally, become lonely, and develop death wishes. And the loss of meaning and existential disintegration is very important. People sometimes call it, in qualitative studies, an existential vacuum. They don't have any reasons for life anymore. They feel their life is completed or a closed book. And when you look at what might be reasons that people think that, then you see that it can be strengthened by societal and internalized ageism. There's a lot of prejudices people have about aging, and prejudices in society forces them to feel a loss of meaning. And finally, cultural and structural context, like the possibility that euthanasia is a possibility, can also determine whether people get death wishes or not, because it can be the opportunity of euthanasia may be a good thing, but it might also provoke the death wishes in people as potential option. And if you look at the ethical and legal considerations as determinants, it's very complex. If you, for example, if you look at euthanasia for psychiatric disorders, I think we all know a lot of patients ask for it, but what you see is a lot of patients also are ambivalent, and their death wish and the wish for euthanasia fluctuates often a little bit over time. So it's very difficult. If you look at dementia, it is complexity with death wishes is the declining capacity. And if you look at older people with accumulation of health deficit in the Netherlands, it can be an official reason for receiving euthanasia. Also, the death wish may also a little bit fluctuate, feeling it's difficult. When do they have enough health deficits that life is not worth living anymore? And as the most extreme is the completed life debate, and a little bit beyond my lecture, but I think if you would really legalize euthanasia for a completed life, it will also affect how people think about death and death wishes people experience. And finally, clinical care communication, the more practical part of my lecture. If you look at the research, and it's mainly qualitative research, there are some barriers to an open dialogue. And that's very important. And what you see is there is some reluctance to discuss death wishes by both professional and patient. Professional think, I don't want to evoke death wishes, and patients often think that a physician or a professional might not be interested hearing their wishes and not able to talk about it. Also, the interpreted complexity and risk of reductionism. If you look at the medical part, often when people present with death wishes, oh, it might be a depressive disorder, and look purely for depression, but neglect easily the existential and the relational aspect related to the death wish. And if you look what should be a good way to care for people and communicate about death wishes is in fact the palliative and relational approaches, in which you really have a conversation with the patient, ask what's going on in them, how they think about them, what they are ambivalent about, how they think about it, and then you can go into a process to explore the death wishes and explore what kind of aspect can be improved and how you can deal with it. So if we go to the end of the presentation, that's an important clinical implication. I think death wishes are much more prevalent than euthanasia requests and are definitely not the same. Not all people with death wishes proceed to request for euthanasia. It is a risk of medicalizing existential distress. I think the existential factors are very important to address somewhere in a patient journey. And a focus should also be definitely be on the psychosocial context and especially the unmet needs. And often there are treatable underlying causes, and they should be discussed and explored with patients. And I think to help them really with their death wishes, a compassionate multidisciplinary care is very relevant. And I think we can learn from the palliative care model in this respect. So that's briefly, just half an hour, my presentation. I prepared some clinical dilemmas for discussion, but unfortunately, as I pre-recorded it, it's very difficult for this discussion. So I will skip it, and it will end with, I think, an important message. In aging societies, the ultimate ethical imperative may not be to enable or prevent death, but to rehumanize life in the face of decline. And to this end, understanding and responding to death wishes is not merely a clinical task, but a societal responsibility. And I think it would be a good start for an open discussion. And I thank you very much for listening to me, and I hope to see you somewhere in the future live. Thank you very much.
Okay, thank you, Richard. He just sent me a photo that he's singing in a karaoke bar in Japan, but we are listening to him, and he makes clear the complexity of death wishes in older people. Let me see. Are there any comments about this lecture in death wishes? Because, yeah, are there any comments, questions? Not really, because here in the Netherlands there's a huge discussion about death wishes and euthanasia requesting younger people, but I think the older people have another complexity in death wishes and the evaluation of the death wishes and euthanasia requests. Not only the decisional competence, but also the issues about completed life. And it was very clear in that model that the patients reclaim control by developing the thoughts about theirs and release of the problems that make me, and we are discussing about that in our research group, if that the death wishes in the patients can evaluate to suicidal thoughts or suicidal suicide, or can develop to euthanasia request. That the mechanism is quite the same, that there is a kind of entrapment for the patients to develop suicide thought or to develop euthanasia request. Does it make any sense that's thought also in the older people? Cindy, can you tell me something about that, about your opinion about that?
Well, I was actually, I've been thinking a lot about ageism in other spheres, and I think that that's such an area that is just goes unseen and overlooked and accepted. And I think one of the cases at the end was just about somebody who's 96. You know, they may just have osteoarthritis, likely more conditions, but I think we don't talk enough about that.
Yeah. Okay. And do you think it's different from for the older people when you compare it to the younger people, or is it the same issues?
I think there are similar issues and unique issues too. That's a whole talk. It's
yeah. Okay. Thank you, Chris.
And I guess when we think about ageism, we also want to think about sort of internalized ageism. We see that in our older adults too. And, you know, I think a big driving factor for a lot of people as they approach end of life, thinking about life, death made is being a burden, right? And what, you know, the impact of their living and death is, you know, on their loved ones. So yeah, I think that's important and relevant, but I guess that too is a you know, form of ageism, right? Internalized. It's a great session. Enjoyed it.
Mm-hmm.
Thank you, Chris. Okay, any other discussion points from any country? In other countries, I don't know from where Canada I see, but are there discussions about the completed life and legislation, or is it only in the Netherlands point? I think in Belgium also, are there people from Belgium now here or not? I'm not sure about it. No. How's that in Canada? Is there a discussion about a completed life or something like that? No.
Most of the discussion right now is about MAID for mental illness. That's dominating our national dialogue.
Yeah, in the past years.
And in itself, not a meeting eligibility. The idea of a completed life would in itself likely meet the test, you know, for MAID, you know, absent the other criteria that we'll talk about.
Oh yeah. Okay, that's a nice bridge to your presentation, I suppose. Chris Kitamura is working as a geriatric psychiatrist at Baycrest Health Sciences in Toronto. And Cindy Creve is also a geriatric psychiatrist at Baycrest Health Sciences in Toronto, and also an assistant professor at the University of Toronto. I met them in 2023 at the International Geriatric Mental Health Rounds that you are organizing in Canada. It's very interesting meetings also, and they will give us an update about the legislation made in Canada. Chris and Cindy.
Yeah. So I could say good morning here. There's at least one Canadian I see, in addition to Chris, and good afternoon. And we just want to thank you for the opportunity to talk about MAID in Canada. But first, I want to acknowledge the work of our colleague, Dr. Mona Gupta, who's a bioethicist and has great expertise in the field, but also Dr. Donna Stewart, who's here and has great expertise as well. And a special thanks to you, to Dr. Moredison, for inviting us and for your support of the International Geriatric Mental Health Network. Next, please. Thank you. So we're going to give you an overview of MAID in Canada, and in doing so, we'll be discussing some of the many challenges with our legislation, which continues to be the subject of national conversation, but it also, of course, draws attention beyond Canada. And I'll also invite you to consider how Canadian MAID laws are similar to or different from the laws in your own countries. So let's begin with a little context next. Thanks. So Canada is a very large country. I wonder how many of you, if any of you, have been there. It's the second largest country in the world after Russia, if you don't subtract the water. And we have 10 provinces and 3 territories. And English and French are 2 official languages. We're very diverse. Just some pictures there of the Bay of Fundy in New Brunswick and Old Montreal in Quebec, and there's Vancouver, and that is Lake Louise in Alberta in Banff, and it does really look that way, but usually there are more canoes in the picture. So MAID's been legal in Canada since 2016, and our laws are federal. That means they're national, but there are regional differences. And MAID access is affected by where you live, because you can live in a big city or a rural area with fewer resources. And the provinces determine how healthcare itself is delivered. And for example, there are provincial MAID teams, but also how healthcare providers are registered and trained and monitored. But the eligibility is national. Next slide. Next, please, Chris. Oh, thank you. Back, actually, I just wanted to go back one more. You skipped. Well, thank you. Just to point out where Chris and I are from, that's the city of Toronto, with snow, though it's 23 degrees outside right now. Next slide, I'm going to talk to you about the eligibility. So MAID's been legal, as I may have mentioned, since 2016. And to be eligible, you have to be at least 18, though discussion about MAID for minors is on the table. And you have to be eligible for government-funded healthcare services, and your request has to be made voluntarily. So without external pressure, like, we need your bed in the hospital, have you considered MAID? And it's essential that the person that is requesting MAID is capable of making healthcare decisions for themselves, so they can give informed consent. And the person has to be suffering from a grievous and irremediable medical condition. So what does that mean? Next slide. The law defines it. It's not a clinical definition. And it means that the person has a serious and incurable illness, disease, disability, which at this time cannot be solely for a mental illness. And the person has to be in an advanced state of irreversible decline in capability, and it cannot be reversed, and they have to have enduring either physical or psychological suffering that they find intolerable, and that the suffering cannot be relieved under conditions that they consider acceptable. So, for example, you can have a treatment-resistant depression as your reason for choosing MAID, but that can't be the only. Let me clarify that. You can't only have a severe depression as your reason, but if you had, for example, advanced lung disease and you are clinically depressed and decide that you don't want to be treated further, including for the depression, you can still potentially be eligible for MAID in Canada. Next slide, please. Until March 2021, somebody requesting MAID would only be eligible if their death was reasonably foreseeable. And with the changes in the laws, we now have 2 tracks for MAID. So in track 1, as before, the death is reasonably foreseeable, for example, a terminal cancer, and there's no mandatory waiting period before you can have MAID. And a person can also choose the date for MAID, and it will proceed even if they lose capacity under track 1. But in track 2, this would be where your death is not reasonably foreseeable, it's not imminent. And as with track 1, either a nurse practitioner or a physician have to confirm eligibility. And this is where frailty sits, and chronic pain and ultimately mental illness alone. And when death is not reasonably foreseeable, the clinician with expertise in the condition has to be consulted as well. Next slide, Chris.
Oops.
Thanks. So almost all MAID cases in Canada, that'll be about 99%, involve euthanasia. So that means being clinically, as everybody here would know, clinician administered. And that would be, as I mentioned, a nurse practitioner or a physician would administer the lethal injection. So it's much less common to have an assisted suicide where the individual would administer the medication, as would be in Switzerland or parts of the United States, like Oregon and Washington, California, I believe. And so I think I mentioned track 1, some jargon. You might see RFND. Track 2, death's not reasonably foreseeable. And conscientious objectors can be the physician, the nurse practitioner, can also be the pharmacist, and you could not want to participate in any phase of MAID. And that is protected in Canada. And we also have faith-based institutions. So that means that you would have to still have an obligation to connect a person with MAID services. But I will introduce the challenge of MAID might not even be brought up or discussed depending on the personal feelings of the clinician. And that can be for discussion. I should also mention that we use a small I. It's not a typo for MAID in Canada, but you'll see it, of course, both ways. Chris, next slide. Before I turn it over to you. Thank you. So Canada is considered among the most permissive of countries for assisted dying, and people have been found eligible for MAID based on their suffering from these conditions and others, but these are just some examples. There are more, and you can have multiple conditions, and you can have combinations. So I think this might be a good place to turn it over to you, Chris.
Great, thanks very much, Cindy, and it's wonderful to be here. So I'm just going to share some data first before we dive in a little bit more to the dementia and mental health piece. And this is overall, and this is the last year we have good data, 2023. T1 and T2 here referring, of course, to track 1 and track 2. And one thing to note is that the vast majority, over 95% of MAID deaths are happening by track 1. So that's a reasonably foreseeable natural death, a much smaller number along track 2. And in track 1, by far the most common medical condition was cancers, as that single basket cardiovascular diseases would follow after that in various forms. But then there's a large portion of MAID deaths that fall in this other category, which I'll come to in a moment. In track 2, this is the non-reasonably foreseeable natural death. Neurological conditions are the most common. But if we break down this other, Cindy already alluded to a large portion of the medical conditions being frailty and chronic pain, and especially in track 2, these make up a large portion of the other, but it's a pretty heterogeneous group. It's also important to remember that people with frailty and chronic pain, they could be eligible under track 1 if they have other co-occurring medical conditions that make death reasonably foreseeable. And this is just a table. I won't go through all of the details, but the point just to be made here is that the vast majority of MAID requests did result in MAID provisions, more than 3/4, with a much smaller number not proceeding to MAID because the requests were deemed, the patient was deemed ineligible, or the individual died from another cause before MAID death, or the person opted to withdraw their MAID requests. And this is a graph that just looks over the years since legalization of MAID in 2016. You'll see the smaller blue bars that have come in since 2021, those of course being track 2, which was introduced in what's called Bill C7 in Canada. And it's a growing proportion, but still under 5%. Another thing to take note of is the fairly brisk increase. So every 3 years or so, the amount of MAID deaths are doubling. The rates of increase are slowing a little bit in the last couple of years, but still increasing. Again, and the track 2 deaths representing a much smaller but growing portion. Overall, if we look at the amount of deaths in Canada that are attributable to MAID, the number is about 4.7% most recently. So this falls below the Netherlands, right, over 5%, and slightly above Belgium, a little over 3%. But one thing to keep in mind is that Canada has got there in less than 10 years, whereas Netherlands and Belgium, for example, it's been roughly 20 years plus. Also important, Cindy had alluded to some regional differences, especially in Quebec. The amount of deaths in Quebec attributable to MAID are now more than 7%. That places it, many reports say, the highest rates of MAID death in the world in Quebec at over 7%. And Quebec, for example, representing slightly more than 20% of Canada's population, but more than a third of MAID deaths, said another way. Okay, and this showing a slight male more than female preponderance of MAID deaths, the greatest proportion in the mid-70s, and much lower rates of MAID in individuals under 50, but there certainly are some cases still. So the numbers have gotten fairly high, fairly quickly, some would say, and it's made the news in a number of places. People talk about record-breaking years in these recent years in Canada. I've shared some of these stats with you. Comments such as the Canada's euthanasia explosion. We've even made the UK news as well, talking about Canada being on track for a 35% increase in state-sanctioned suicides. They referred to it in 2022. Also made the US news. This is a very recent publication from the New York Times just this past summer that raises the question: Canada offers medically assisted death to patients without a terminal illness. So referring to our track 2 pathway to MAID and asking the question, is that kindness or cruelty? And in a bit more sort of striking comment on it, The Atlantic, also out of the States, it talked about the world's fastest growing euthanasia regime, so calling it a regime, and seemed to be calling attention and possibly caution to what Cindy alluded to earlier in our track 1. So with reasonably foreseeable death, there can be that waiver of final consent if patients can set their date for MAID, even if they lose capacity. It's important to keep in mind, though, that less than 5% of deaths in track 1 are a result of people who have had the waiver of their final consent. Also, perhaps cautioning against our track 2, reasonably foreseeable natural death, not present. I'm going to hand it back to Cindy.
Thanks, Chris. Next slide, please. And I think we're going to discuss this too, the notion that for some people, having the ability to select MAID is a comfort, and they may find that they're eligible and not actually proceed with that. We didn't include those statistics, but it's something that we might talk about. Chris, if you could just advance it to the next slide. Thank you. One back, because I want to just go over again. Well, I could just review it, but I wanted to start with Canadian MAID laws going back to grievous and irremediable, because there are challenges embedded in that criteria. So if grievous and irremediable, as I mentioned before, means a serious and incurable illness, disease or disability being in advanced state of decline, and suffering that is not tolerable to the person, and the suffering can't be relieved under conditions they consider acceptable, are key points, because the thresholds aren't fixed. And grievous is going to depend on the patient, on the person's perception of the intolerability. And so many clinicians find this ambiguity challenging. And irremediable doesn't mean that everything has been tried. A person may never have tried ECT, for example, and we could, and anticipate what will be the case with, well, we can't with MAID for mental health issues, because what does a person have to be the person? Does it the person that has to make the decision entirely, or does the clinician get to say, no, this person will need to have ECT? But for now, as it currently sits, it is from the person's perspective what is deemed unacceptable. And of course, the time frame, it's vague. So you can have MAID almost immediately under track 1 within days of approval. And it's common to have it within a few days or a few weeks, but it can be up to several months especially when there's a waiver of final consent involved, which we now have, so that if capacity is going to be lost when you have a death that's foreseeable, it could be months. So is there a definitive time point where you say, sorry, you can't have MAID, or you have to go through the process again? Not to my knowledge. There's no fixed timeline. Next slide, please, Chris. So track 2 is also much more difficult for providers for a variety of reasons. They may be involved in track 1 assessments and not track 2. And Dr. Madeline Lee was quoted in the article that Chris mentioned from The Atlantic. And she said, it's odd to me, there's no other branch of medicine where we just do what a patient wants without asking, is this the right decision? So it can stir up a lot of feelings, even if you're very much willing to be a MAID assessor or be involved in the process. But another big challenge is how to address the concerns of many, including disability advocates, that it's a lack of access to social services and support, and poverty itself that may be underlying some of the requests for MAID. What are the impacts of social determinants of health, and other factors like loneliness and social isolation? A former minister of disability rights made a comment about something to the effect that it's easier to get MAID in Canada than it is to get a wheelchair, motorized wheelchair. Let's go on to the next slide, please. Thank you. So in 2023, the Angus Reid Institute, which is a nonprofit research foundation, had concerns that MAID was a way to avoid dealing with social disparity. And this is a picture from 2022 where this man was struggling with poverty and homelessness and was requesting MAID. And the issue, his suffering was stemming from his homelessness and his poverty rather than his lung illness, which actually did make him eligible. And by definition, all track 2 patients are disabled in some form because they have medical conditions that limit their daily functioning. And disability advocates have been upset with this notion, some of them. And also, just another point is that national data in 2023 found that track 2 patients are more likely than the average Canadian to live in the lowest income neighborhoods, which is actually the case for people with disability in Canada, even if they don't want MAID. So social factors to consider. Next slide, please, Chris. Access to palliative care and psychiatry and social supports, which might influence whether somebody requests MAID, are also not equal. And rural and remote areas have longer waits for these services, and many people don't even have access to primary care physicians. And as I mentioned, our country is very large. And as you can see on the map, parts of Canada actually don't even make the scale because it says there's no assigned value because they're too remote. I am just going to make a few comments about the next challenge, and then we'll turn it back to Chris. Thank you. So another challenging scenario is dementia itself. And dementia was a medical condition, not the only one, in 241 MAID cases in 2023, but it was the sole medical condition in a smaller number, 106 MAID cases. 2023 is the last year for which we have reported data. There's some provincial data, but we're waiting for our next report to come out. So somebody is technically might be eligible under both track 1 and track 2, but it's tricky. And you can't say if you have early dementia and you're capable, you're likely not going to be eligible because you still have a lot of capability and functional ability. And you can't say I want MAID in 5 years. That's not legal, except in one province, which makes it challenging. Next, please. Next slide. So just some data to report. If you look at dementia as the sole medical, about just over 76% received MAID under track 1 and a smaller number under track 2. Next slide, please. Thank you. So the problem with dementia is it's a case of either being too early or too late. So too early, you're not going to meet eligibility criteria necessarily unless you have another condition. And a point to make is that you may have, I'm living just fine with my COPD, but I don't want to, I've just been diagnosed with dementia and my mother died from it. And I don't want to live that way. And I'm suffering even from the knowledge. And whether it's cancer or end stage or lung disease, you may actually be eligible. The suffering is not tied to the particular condition. So another example, of course, would be somebody that's very depressed, who's suffering a great deal, but their condition itself, if they weren't depressed, anyway, challenges, and we can discuss it. But under track 1, of course, death is reasonably foreseeable, and that might not be the case, or it might be, but if somebody with dementia has a reasonably foreseeable death, they can actually sign a waiver of final consent and they can lose capacity, but it's tricky. It's a very narrow window. So again, by the time somebody with dementia has an advanced decline, they may no longer intolerable suffering. They may be at the point where they can't consent. Please advance to the next slide. And just the next slide is Chris. Thank you. So advanced requests in dementia is when I reach stage X and I don't recognize my family, that's when I want MAID. It's not exactly legal in Canada, except for Quebec, which is a different case. Since October 24, they do allow some advanced requests, and in their legislation, under strict criteria, the practitioner won't be prosecuted. I don't fully understand how that works against the backdrop of national legislation. Maybe Dr. Stewart might have some more insights on that, but it's a complex area. And how do we balance present wishes against a future state? And if we work it with older adults and we've seen people with dementia, a person in the later stages or moderate stages may be perfectly content or seem content, not agitated. What do? We don't have a clear-cut understanding of policy there. And a final slide that I want to make before turning it back to Chris is, Chris, it's not advancing.
Oh, I think it might just be lagging. Let me try again.
Okay.
Is that better?
I can't see the next slide. Can other people see the next slide? But it's, I can talk to it, but it was more of an image. That's a good segue and transition. Thank you. I just wanted to share with you. Yeah, perfect. So Robert Munch, if you're from Canada, would know, is a very beloved children's author. And on just September 15th, he spoke about his decision to have MAID, and he was approved. He doesn't have the date yet, but he's been diagnosed with dementia. And he also, though, has Parkinson's. And he made a comment about not being able to drive or, can't write anymore. He said something about it's been whittling away of who I thought I was. Very interesting questions. And another area of challenge, I will turn it back to Chris to talk more about. Thank you.
Great, thanks, Cindy. And maybe just let me know if the slide doesn't advance now, because I think there's a bit of a lag, and I'll just try it again. Good. All right, but I'm gonna, in the final section, we're gonna speak about MD-SUMC, as we call it in the Canadian legislation. So MAID for mental disorders as the sole underlying medical condition. This will, of course, fall under track 2, so conditions where death is not reasonably foreseeable.
Chris, the slide hasn't advanced.
Oh. Okay. You see it now? Good. Is that okay? All right, thanks. Yeah, just let me know, because it's going on mine. Good. Okay. So this MAID for mental disorders as a sole underlying medical condition came into the discussion first in 2011 with Bill C7 and introducing the track 2, but there was the mental health exclusion. So it was delayed, and it was subsequently delayed a second time, and absent any further delays, it's going to become real in March of 2027 in Canada, so less than 2 years out now. I want to again highlight the work of the MAID for Mental Illness expert panel. Simona Gupta was on there, Donna Stewart was on there, and very important work was done, and including highlighting 4 key areas of challenge that we'll walk through. One of them is the assessing irremediability in mental illnesses, where we know these are conditions that can have unpredictable and variable courses. Also assessing capacity, especially now in mental illnesses when the conditions themselves can result in cognitive distortions. Importantly, assessing what are rational, autonomous, values-driven wishes for MAID versus suicidality in the context of a mental health symptom. Third area, and the fourth, which has been alluded to both by Cindy and also in Richard's talk, is considering addressing suffering from social determinants of health, especially as we know people with mental illnesses are marginalized and socially disadvantaged very often. Okay. And hopefully you're seeing a slide on public attitudes. So this is also from the 2023 Angus Reid poll. One thing to note is that, not shown here, if you look at the Canadian public's attitudes towards the current MAID laws in general, about 2/3 are in support. When you ask about MAID for mental disorders as a sole condition, the support in the blue bars is much lower, less than 1/3 support that. While there's been some warming to the area, it's still the majority of the Canadian population oppose.
Chris, your slide hasn't advanced. I was just looking at the,
yeah.
Sorry, I was looking at the
maybe
chat.
I'm going to try just once more to screen share. I'm going to try
okay,
resharing. If you just bear with me 1 second. Okay.
I can also share.
I'm going to try resharing.
Okay.
Apologies.
Yeah, and worst comes to worst, I can do it as well. I was just going to.
Okay. Do you see it now, a slide public attitude?
It says, yeah.
Okay, good. Yeah, so just highlighting MAID laws in general in Canada, the public support for current MAID laws about 2/3, but if you look at MAID exclusively for mental disorders as a sole condition, less than 1/3 in support.
Sorry, I don't see the slide. Am I the only one that?
Oh, okay.
Apologies. Now I see it.
Now you see it?
Sorry.
Okay.
Yeah.
All right. I'm going to say next slide, and maybe tell me if you don't see a next slide. Okay. Good. All right, you see the next slide, the article? Okay, good. So now assessing irremediability, I think this has been discussed in this forum, and people are probably aware from the work of Cisco Van Veen and colleagues, who did a few years ago a very helpful Delphi study with experts from Netherlands and Belgium trying to establish criteria for what is irremediable psychiatric suffering as a clinical decision-making tool. Came up with 13 criteria. Won't go through all of them, but I'll just highlight a couple around diagnosis. So some sample criteria to consider is consider the narrative experience of individual with suffering from mental disorder from onset over time. Consider, of course, as has been alluded to, the systemic factors that can cause or maintain psychiatric suffering, including social supports and services. Around treatment, if indicated, ECT should have been attempted. According to this Delphi study, psychotherapies, appropriate ones, must be attempted. If necessary, substantial efforts should be made to improve someone's social context. And because all reasonable treatments must be tried, the suffering must be present for several years in the context of psychiatric illnesses. Next slide. All right, and just briefly, I want to highlight the work in Canada of CAMAP, which is the Canadian Association of MAID Assessors and Providers, and they provide guidance and education and training both to clinicians as well as some information to the general public as well. And they produce some of these guidelines around these challenging areas. One of them is for assessing incurability. One thing to remember, and I had a nice discussion with Dr. Gupta about this, but we want to think about the degree to which something is curable has both objective and subjective components. So us as experts and providers know the evidence around certain treatments, but patients, of course, have their own lived experience and their own expectation of curability. And as Cindy alluded to, in Canada, the treatments tried must be acceptable to the patient. And how do we determine what's acceptable? Well, it's informed by a number of variables, importantly by values, but it may also be informed by things such as fears and misinformation. And the guidance appropriately says it's important to address fears and misinformation. Again, considering the totality of the patient's experience and goals of care, and you'll see wording such as needing to have tried many or the majority of treatments, but not necessarily all available treatments. Slide. And again, this is a different document, but a model practice standard for MAID, and they do a very helpful job distinguishing MAID requests from suicide. And again, along the same lines, you want to make sure that the request for MAID seems consistent with the person's values and beliefs, that it's clear, unambiguous, that it's enduring over time, and that it's rationally considered during a period of stability and not during a period of crisis. Also important to remember that a MAID, may seem obvious, but a MAID request in itself is not a psychiatric emergency and not a reason for someone to be hospitalized. And also that someone's deemed ineligible for MAID, thinking about the supports that are needed around that person, because that could be a higher risk time for them. Going to the next slide. And CAMAP also provided some guidance around care coordination, and we've talked about how in
advance beyond.
Oh, okay. All right. Did it advance now, Cindy?
Oh yeah. Right. So now we're
okay,
on the
great.
CAMAP. Okay.
Okay, care coordination. And as Cindy alluded to, in Canada, amongst different provinces, different region, different models of care. So it's important to ensure that if we're thinking about MAID for mental illness, that patients have access to mental health services, access to providers that are able and comfortable, especially along this track too. It's controversial, that there's guidance and training, and then of course, coordination of MAID referrals and services. All right, next slide, Cindy, do you see it? Older adults? Perfect. Okay. So just building upon some of what Richard said is we have to think in older adults in particular, and we want to make sure that the request, of course, is voluntary and not related to undue pressure, and that would include pressure from family. We heard about ageism. So I mentioned myself, the self-ageism and feelings of being a burden. There's societal agent that lives, of course, quite rampant. And, you know, what is the cost, the cost associated for caring for an older adult? What is the value of an older adult's life? Healthcare providers, we've heard, may not offer, older adults are less likely to be offered active treatments. Of course, older adults may encounter cognitive decline of various degrees that can undermine their capacity. And social isolation and loneliness, while a major issue in all age groups, is especially amplified in older adults. And a lot of good work's been done looking at that issue. The CCSMH in Canada, the Canadian Coalition for Seniors Mental Health, for example, has put out some great guidelines and products that related to social isolation and loneliness in older adults. And just before we finish, thinking about, so age, does age itself make someone eligible? Does older age make someone eligible for MAID? Slide. Nope, not yet. Age and eligibility? Yeah. Perfect. Okay. So no, the answer is no. Age alone does not qualify someone for MAID, but of course, older adults because of their advancing age, may be eligible under both Track 1 and Track 2. Under Track 1, if they have other conditions that make death reasonably foreseeable, or under Track 2, of course, if they're experiencing increasing frailty and other conditions that cause irremediable distress and suffering, even when death is not reasonably foreseeable, such as chronic pain, disability. Okay, and the next slide, do you see it? Not yet? Okay, one more. I think I have to do it twice. That's the key. Okay, so just some final thoughts, and maybe we can segue into the discussion. I think what we really see is that...
Three times lucky.
Okay, one more? Okay.
It's the last slide, perfect.
3 times lucky? Got it? Okay, good, okay. So I think just one of the keys, and it's not a challenge that's unique to Canada, but just thinking about how social and structural inequities in society impact end-of-life decisions, and how are we going to protect vulnerable populations, those with mental conditions, those with disabilities, older adults alike. Cindy and I are our hats as geriatric psychiatrists. But maybe I'll stop sharing, and we're happy to open it up for questions. Thank you very much.
Okay, thank you very much, Cindy and Chris, for this very nice overview and update from Canada. Are there any questions? Donna Stewart, please, could you introduce yourself shortly? From which country?
Yeah, I'm Donna Stewart from Canada, and I want to thank my colleagues for a great presentation. I also serve on the Chief Coroner's May Death Review Committee. So I get to see the problems, which are few and far between, thank heavens, but there are a few. The one thing I wanted to add to my colleagues' presentation is that under Track 2, the assessment period is a minimum 90-day assessment period, but many of these take much longer than 90 days. We've had ones that have taken up to a year or more, and the assessor shouldn't feel constrained to finish this by 90 days. Some take much longer.
What are some of the reasons that they take longer?
Yeah.
They're more complex cases. And the commonest ones that I see are people with sudden spinal injuries. So young people who suddenly have a major spinal cord injury and end up quadriplegic really don't have a chance to adjust to this major life event within 90 days. And so in reviewing the literature, we have come to see that most people have a much better adjustment after a year. And so we tend to ask for these people to have a longer assessment period, to try some rehabilitation. And if they're still feeling that after a year and still meet the criteria, then I think it's fine for them to go ahead with their MAID. But we see some of them drop off during that time period and learn to live with their disability.
Okay. Yeah. Any comments, Cindy?
You know, I learn all the time, and Dr. Stewart has vast experience, so it just always leads to more questions. And
yeah. Okay. Thank you, Donna. There's a question or comment from Martje Goudaert. Please, can you introduce yourself? From which country?
Yes, hi, my name is Martje Goudaert. I'm from the Netherlands, working in old age psychiatry as a psychiatrist. And I was wondering, or maybe I missed it, but who performs MAID in Canada? Is it the general practitioners, like usual in Holland, or psychiatrists, or both?
Yeah, in Canada, it's physicians and nurse practitioners. I believe those are the only health disciplines. Psychiatrists have played an interesting role to now. I mean, my approach to now is, while we're physicians, I haven't personally done assessments, because I often tell people that I don't treat the medical conditions generally for which people are principally getting approved, but often we are approached to comment around coexisting mental health conditions and how that could affect capacity. I know it's not a direct question, but I think that's another area of stigma, right? Where anytime, and Dr. Stewart, you might see it as well, right? And review when people are referred for MAID, if they have any type of mental health condition, right? There's that extra level of pause when, of course, we know that people, with depression or other reasons, they can still certainly be capable, to consent, to MAID.
Let me just add a few things to that. So a physician, there are psychiatrists that do administer MAID, and there are other clinicians that are involved in the process. So a pharmacist would be involved in the medication aspect.
Obviously,
and yeah, but one other thing that we alluded to is Chris and I work in a place that there are a few places that are considered faith-based institutions. So so there's like St. Michael's Hospital is a Catholic organization. So yeah, so that also affects things. So again, if somebody in our setting in the retirement home or the long-term care aspect of where Chris and I work, that would proceed, but I've been part of the MAID assessment team in the hospital section, but they wouldn't actually have MAID on site. So there's other complexities involved.
Thank
you.
you. Okay.
Thank you.
Good. Donna, last question because of the time.
So in Canada, the vast majority of these assessments are done by family physicians. But as my colleagues have pointed out, there's a wide variety of other specialties involved. Emergency docs, surgeons, physicians, even OBGYNs. About 10% are psychiatrists. I tend to get a lot of referrals because I work in a network that has 5 hospitals. So I've seen over 400 of these. So, a wide variety of specialists are involved. About 5% are nurse practitioners with special training.
Okay, thank you, Donna. There's also an interesting comment of Nuria, and Cindy has answered the question. Nuria has no microphone, so please read the chat. And now we come to the end of this network meeting. First of all, I really want to thank Cindy and Chris for their very nice, good presentation. I want to thank all the people who were here. The next network meeting is on the 19th of December at the same time. We see that I hope there will be more people involved in these network meetings. So please spread the news. In my opinion, it's nice to discuss, so maybe we can make a case discussion next time and talk about and discuss about it from the different perspectives from the different countries. If there are any topics, ideas for presentations, etc., please let me know. info@iaadm.org. And I hope to see you all in December. Thank you for attending this meeting. Thank you so much. Bye-bye.